Hello, everyone. As part of our Safe Access programs, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Sachs Communications, and I am your technical producer today. It's my pleasure to welcome you to today's webinar, the Michigan Appropriateness Guide for Intravenous Catheters, also known as MAGIC. And now, I'd like to extend a very warm welcome to Nancy Moreau, who is our moderator today. Nancy is a vascular access consultant, educator, PIC specialist, and the founder and CEO of PIC Excellence Incorporated, an internationally recognized speaker on PICs and general issues with intravenous practice. Nancy's areas of focus include venous access devices, central venous catheter troubleshooting, education with ultrasound, infection prevention, use of thrombolytics, and management of complications with infusion. Nancy, I am so glad to be working with you on this special session, and we thank you for all of your support in moderating this MAGIC webinar for so many people in our international audience today. Are you ready to get started?
I am, Emily. Thank you so much for that lovely introduction. Good afternoon, good evening, and good morning to everyone. It's a pleasure to have you join us today for the webinar, The Michigan Appropriateness Guide for Intravenous Catheters. It's also my immense pleasure to introduce you to Dr. Vineet Chopra. Dr. Chopra is a dual hospitalist and investigator in the Department of Medicine at the University of Michigan Health Systems. A health services trained researcher, Dr. Chopra's research interest is focused on improving the safety of hospitalized patients and preventing hospital-acquired complications and infections. He's particularly interested in preventing complications related to vascular access devices, including central venous catheters and peripherally inserted central catheters or PICs. Dr. Chopra's research has been widely published in leading journals, including the Journal of the American Medical Association, the British Medical Journal, and the Annals of Internal Medicine. Dr. Chopra is an assistant professor of medicine and a research scientist at the Patient Safety Enhancement Program and the Center for Clinical Management Research at the Ann Arbor Veterans Affairs Medical Center and the University of Michigan Health Systems at Ann Arbor, Michigan. And now, Dr. Chopra discloses the following. Under his grant contract funding, Dr. Chopra is involved with the Agency for Healthcare Research and Quality, the National Institute for Health, the National Institute for Aging. He's involved with the Blue Cross and Blue Shield Foundation of Michigan, the Veterans Health Administration, the Centers for Disease Control and Prevention. Dr. Chopra also discloses intellectual property with the ePIC technology and also says that he will not discuss any off-label or investigational use within his presentation. And so now it is my pleasure to talk about the continuing education that you'll be able to receive for both physicians and nurses. This educational activity is approved for 1 contact hour and is jointly provided by Synaptic and Sachs Healthcare Communications. The accreditation statements are outlined as you can see on your screen. A link to obtain the continuing education credits will be available for you at the conclusion of this webinar. The support for this educational activity is made from AngioDynamics. So now it is my pleasure to present Dr. Chopra. Are you ready, Dr. Chopra?
Thank you, Nancy. I am indeed. And I am just looking at these numbers and I see 915 people on the talk today. So I am very grateful to all of you from all over the world for being here to talk about my little project, the Michigan Appropriateness Guide for Intravenous Catheters, also known as MAGIC. My learning objectives for all of you today are the following. I want you to be able to describe the RAND UCLA methodology for developing appropriateness criteria by the end of this presentation. I also would like you to be able to list some key findings from the MAGIC document and discuss how MAGIC has helped inform clinical practice and the care of hospitalized patients. So with that background, let me tell you how I'm going to proceed with the talk today. I'm going to begin with some clinical cases and jump right into the rationale for why we created MAGIC. I'll spend some time talking about the methodology behind MAGIC because I think it's important for you to understand just how we created this document. I want to focus a few sentences about the strengths of MAGIC end with some conclusions, and hopefully have time for plenty of questions and answers. So let's begin. Clinical cases. Let me start with this story. A 44-year-old male who presented to the ER with acute alcohol intoxication. He has a history of diabetes and polysubstance abuse. He's homeless, and multiple providers attempted to place a peripheral IV in this man's arm. Unfortunately, they were not successful, and the ER physician then asked for a PICC to be inserted. Was this the best choice for this patient? Let's take another case. This one is an 82-year-old male with a rare form of melanoma. He's admitted to the hospital with severe GI bleeding. On arrival, he's in shock. His heart rate's in the 130s. His blood pressure is 70/30, and he's cool and clammy to touch. Now, he's in the intensive care unit where the ICU physician calls the PICC team and asks them to place a stat PICC for central access. And my question is, was this the best choice for this patient? Let's take one more. This one, a 62-year-old lady who has severe multi-lobar pneumonia. She's been in the hospital for a while, 11 days, but is now ready for discharge. With her hospitalization, she's become debilitated. Her physical therapy team recommends rehabilitation, but she still needs 4 more days of IV antibiotics. And the hospitalist caring for this patient then asks for a PICC to be placed for a discharge. And the question again is, was this the best choice? What do these questions have in common? Are we comparing apples to apples or apples to oranges? Now, I know with the audience on this group today, I don't have to tell you this. These questions share in common the fact that they all involve choosing a vascular access device. And we know that safe and reliable venous access is a key requirement for clinical care. But the evidence base for making these decisions regarding vascular access is indeed limited. And despite this limitation, despite the fact that we have little evidence to guide us, we clinicians have to make choices every day regarding not only which device should we use, how best to use them, but how best to also care for them in daily practice. And I will submit to you today that I think often we don't make good choices. Let me show you some data that makes this case. Now, this is data from a study that we published in JAMA just last year, looking at the indications for why PICC was placed in 10 Michigan hospitals. This is data from over 3,970 PICCs. Let me walk you through this slide. Each of the vertical bars here, if you follow my cursor, is a hospital. The height of the bar, right here, reflects the percentage of central lines that are PICCs compared to central venous catheters. So this hospital here on the left, 90% of devices are PICCs, whereas this hospital here on the right, less than 50% are PICCs. The colors within the bars reflect the indication recorded for why the PICC was ordered or placed. The light blue here is home antibiotic treatment, the red is difficult access, and so on and so forth. Now, I want to make a couple of points about this slide. First, even in this small group of hospitals, just 10 hospitals, notice how the use of PICCs varies dramatically, from as high as 90% to as much as 50%. Also notice that no two bars actually look the same. That is, the colors in the bars for indications don't map to another hospital. In fact, we have now expanded to 51 hospitals, and we're still unable to find 2 hospitals that look identical. And for a device that has real risks, I will say that's a shame that we don't standardize practice in a way that's much more predictable. It's not just about why we use them, it's also about how we use them. So this is data looking at dwell time from the same 10 hospitals. And what you'll see here is about a quarter of these PICCs, so almost 1,000 devices, come out within 5 days of going in. In fact, over 50% are removed by 14 days, again suggesting that this type of use could potentially be inappropriate or avoidable. So the question I have for each of us today is, why do we make these decisions and these choices? Well, let me tell you what I think about a vascular access device. I'm always weighing pros and cons. And some of the things I weigh in my head include the following. What am I trying to infuse? Do I have the right equipment or providers available to me? Are my providers skilled enough? Are the patient's preferences taken care of? And if that wasn't hard enough, there's also all this stuff. Contraindications to certain devices, the patient's anatomy, the insurance status, can they actually get the device they need and pay for it? And what about the disposition? Where are they going to go with this device? So it's not uncommon that I hear people saying, I'm not sure if this device is appropriate. What do you think? And again, I want to push us to start thinking about, why aren't we sure? We live in a world where we have technology to do incredible things, and I would submit that it's time that we have the right guidance to be able to do the same for vascular access devices. So here's my version of why I think we're not sure. First, there's never been a Vascular Access 101 course. This is especially true for physicians like me who often order these devices but don't fully understand the risks and benefits of one versus the other. Second, who owns this problem of vascular access device decision-making? Is it the surgeon, the radiologist, the nurse, the medicine doctor, or the hospitalist? To date, there's never been a single specialty that has actually stepped up and said, this is something we want to tackle. And third, as I mentioned earlier, the evidence base is weak and fragmented. And it's not surprising when you think about the fact there's never been an owner of the problem. But there's a deeper problem that I want to highlight here. And that is that I think there is limited recognition that there is a science to choosing a vascular device. It's not just about what's convenient and what's available. It's also about what's safest for the individual patient. This is why we created Magix, to bridge the gap from the evidence to practice to provide guidance where none specifically existed. Now, we had some key considerations I want to share with you today when we thought about creating Magix. First, we really wanted to focus on an approach that's evidence-based. We wanted to use available data to inform our decision-making because it was no good just doing opinions. That's exactly what we have right now. Second, we wanted to synthesize diverse views. It doesn't take a genius to know if you want to choose a vascular access device, you've got to have key stakeholders from all the specialties involved to come up with the best choice. Third, it wasn't just about clinical guidance when we created Magix. It was also a tool that would allow us to focus on measurement and evaluation to understand who's doing the right thing versus who could improve. And finally, perhaps most importantly for me, selfishly, was to help physicians understand the science so that you, the many vascular access specialists out there, don't have to fight these battles moving forward. Let me tell you a little bit about the methods then and how we created Magix. We used the RAND UCLA appropriateness methodology. By way of background, this was developed in the mid-1980s by a guy called Robert Brooke. It was specifically created to enable the measurement of overuse and underuse of medical and surgical procedures. And the term appropriateness is very specific in the RAND UCLA method. When I say something is appropriate in this methodology, it means that the relative weight of the benefit versus the harm of a procedure favors one or the other, regardless of cost. And this is important. We're not taking cost into consideration. The link here at the bottom will give you more information on the RAND UCLA method if you're so interested. Now, this was particularly useful for Magix as a methodology. First, it allowed us to synthesize all of the available evidence and blend expert opinion to fill in the gaps where we needed more guidance. Second, unlike other consensus-based guidelines or group, the focus of this methodology is not to get everyone to agree, but rather to minimize artifactual disagreement. Now, when I say artifactual disagreement, I mean misunderstanding of a scenario or failure to include an appropriate device. And the beauty of this methodology is that it allows us to take input from panelists to clarify scenarios and ensure ratings are consistent. Now that's a mouthful, so let me walk you through how this actually happened when we were doing Magix. Here's an example of a group process for chronic kidney disease. When we got the first round of ratings back from panelists for PICC use in chronic kidney disease, it was all over the map, highly variable after the first round. When we met together in a group, our panel nephrologist, our expert, clarified that really it's about the patient who has stage 3B or greater chronic kidney disease, where venous access preservation is paramount. And this is where you should start thinking about PICC appropriateness. And so we then recreated the scenarios based on this feedback to actually specify stage 3B or less versus stage 4 or more. And when we did this, the ratings became more consistent. We could not have done this without the group approach, which allowed us to create, I think, a highly evidence-based document and a document that made a lot of clinical sense. So how did we create Magix? There were several steps. The first step was a literature review and synthesis. The second was to identify panelists and develop a list of indications. We call this scenarios. The third step was actually to do ratings of the actual indications. And this happened in 2 rounds. In the first round, every panelist got all of the rating documents and did this by themselves. That is, there were no interactions between panelists in terms of discussions as to what may be appropriate or not. And then there's a second round where all the panelists met and had a group meeting. This allowed for interactions and discussion around the rating statements. And finally, we developed and shared the statement regarding appropriateness, which all of you today know as MAGIC. Let's take each of these boxes one at a time, beginning with the literature review and synthesis. Now, this was very difficult to do. We actually hired 2 full-time research librarians at the University of Michigan to help us with performing this search because, as I mentioned, the evidence is very fragmented and all over the place in terms of databases. So we searched multiple databases using multiple techniques. We used Sentinel or landmark articles that all of you would recognize. We added to this mesh terms such as thrombosis, CLABSI, vascular device, and then we added keywords such as PIC, central venous catheter, midline, and peripheral IV, to allow us to get all the relevant material for discussion. Now, we also included relevant guidelines where they were applicable, and all panelists on our group received these materials on a USB drive, so everyone had access to all of the materials necessary to make decisions. So the next step was to identify these panelists. Now, I'm proud to say we had 15 members that were highly multidisciplinary. This included infectious disease physicians, critical care doctors, hospitalists, not 1 but 2 vascular access nurses, a clinician and an educator, and a host of subspecialists, interventional radiology, hem-oncology, nephrology, and surgery. And these are people whose names you will recognize. They were eminent scholars and scientists. What I'm most proud of MAGIC is the fact that we actually also included a patient who had received multiple vascular access devices. And we wanted this person included because we wanted to include the patient perspective. When you're thinking about placing a more invasive device in an individual, surely you should take that patient's account into consideration. So here's a picture of the actual MAGIC meeting. Let me show you who these people are. This is Dr. Stephen Bernstein. He's actually one of the authors of the RAND UCLA method. That's me sitting here on the left-hand side. And next to me is our patient panelist, Georgia Ann Ziegler. Notice how we're all sitting in a square. We're all facing one another. No one had superiority in this arrangement. Everyone was able to speak and look at each other eye to eye. Here's another picture of the actual meeting. You'll see that we were all, again, seated in front of each other with names and tags. And by the end of the meeting, we still were friends. We were able to actually get together and talk about our recommendations and have a nice glass of wine. The final step was to develop a list of indications, and rather than go through every step of this process, let me show you what this looks like conceptually. So here's how we did it. We began with systematic review of the literature, which is down here at the bottom. We then specifically included areas of controversy and ambiguity because we knew that people out there still deal with this every single day when it comes to choosing a vascular access device. And then I asked each of our panelists to give us a top 10 list of problems in their field, so that the issues that the interventional radiologist saw and the surgeon saw could be discussed in a way that was clear and transparent among the panelists. For each indication, we included the proposed duration of venous access, the indication for venous access, and the nature of the infusion. We obviously need this to think about what device is appropriate. And we also included patient characteristics, device and provider characteristics, because this makes a difference when you think about what's appropriate or not, given the resources available. We focus on maintenance and care practices and treatment of complications, and all of these factors came together in developing the clinical scenarios and creating the appropriate indications shown here in the red square. In total, after all this work, we had almost 665 individual scenarios for ratings. This was not an easy task. Let me talk a little bit about the rating process because it's important you understand how this took place. As I mentioned earlier, there were 2 rounds in the modified Delphi method. In the first round, the panelists received the scenarios and the ratings, and they got instructions, but there was no group interaction between panelists or discussion. Now, in the second round, we brought all the panelists as a group to discuss the actual ratings in Ann Arbor. During this meeting, we only focused on areas of disagreement or when ratings varied, for example, like the chronic kidney disease scenario I discussed earlier. And this in-person meeting, as you saw in the photos, was moderated by Dr. Steve Bernstein and myself. How did the ratings actually occur? For each scenario, Panelists were asked to weigh the risks of benefits to harms, again excluding costs, using a 1 to 9 scale. A rating of 1 indicated that the harm outweighed the benefit, and therefore this was an inappropriate decision for a vascular device. A middle rating of 5 indicated that the harm and the benefit were either equal or unclear. This was a neutral indication. And a rating of 9 indicated the benefit far exceeded the harm, and therefore this was an appropriate indication. Now, because everyone rated the actual scenarios, we used the panel median ratings, that is the middle rating of all panelists, to determine whether an indication was appropriate or inappropriate. So if the median of the panel fell between 1 to 3, this was an inappropriate indication. If the median fell between 4 to 6, this was neutral, and 7 to 9 was appropriate. Now, one of the beauties of the RAND UCLA method is that it allows for disagreement, and it defines when this occurs. So when at least 5 of the 15 members rated a scenario on opposite ends of the scale, after our second round of discussion, we felt that there was disagreement. And only the scenarios or indications without disagreement were classified as being appropriate or inappropriate. So if we all disagreed, no decision about appropriateness could have been made regarding that indication. Finally, we developed and shared indications, and as most of you know, this is in the Annals of Internal Medicine, and is published as a standalone supplement of 50 pages. I encourage you all to read it if you haven't already. It's also available on our website, improvepic.com. Let me walk you through what this looks like. Now, the focus of MAGIC was the PIC, which is central in the middle. But it's impossible to talk about PICs if you don't think about other vascular access devices. So for all the scenarios, we compared PIC use to peripheral IV catheters, ultrasound-guided IV catheters, midlines, non-tunneled and tunneled central venous catheters, and ports. So this was really a comprehensive overview of which vascular access device is most appropriate compared to PIC lines. Here's a sample of the recommendations from MAGIC, and let me walk you through what this looks like. So this is Figure 3, Venous Access Device Recommendations for Infusion of Peripherally Compatible Infusates. The way the MAGIC works is you have a proposed duration of infusion on the top and a device type on the left, the same 6 devices we just talked about. The colors in each of these squares reflects whether or not the rating was appropriate, shown here at the bottom. A white square is neutral, a dark blue or green is inappropriate, and a lighter shade is where there was disagreement. So for a typical hospitalized patient whose length of stay is less than 5 days, you have a number of devices you can choose from: peripheral IVs, ultrasound-guided IVs, CVCs, and midlines. Notice there's also preference statements here. So for instance, in the case of critically ill patients, central venous catheters are preferred if needed for 6 to 14 days, given the risks of thrombosis associated with PICs. Also note that there's a dark green square for PIC placement less than 5 days. Our panelists felt this was not an appropriate use of a PIC for a peripherally compatible infusate, especially when you have 4 devices that could be used for this indication. Now remember what I showed you at the beginning of my talk. Approximately 25% of PICs go in for this duration. And so by MAGIC standards, that would not be an appropriate device for that particular duration. Let's walk through another one. This is a venous access device recommendation for non-peripherally compatible therapies. So again, you've got the duration of infusion up here on top. You've got the devices across the side. Notice now that all the peripheral devices are dark colored, which means they would not be appropriate, but that you have a CVC and a PIC in light blue, which means that they are appropriate at all durations. Notice also that we begin to see a white square here. The tunnel catheter becomes neutral, because panelists felt that if you're going to be giving non-peripherally compatible infusions for periods beyond 15 days, you should start thinking about a tunnel catheter, if appropriate, as early as 6 to 14 days of use as well. This is again a strength of MAGIC because it allows you to do a little bit of forecasting and thinking ahead as opposed to being reactive when it comes to vascular access device choices. Let's do one more. This one was the most contentious of all of the discussions. This is venous access device recommendations for difficult venous access. Notice here that we've got a number of choices, very similar to the peripheral recommendations, but notice the blue, that there was disagreement on the appropriateness of the PIC for durations less than 5 days. Just by way of background, this comes down to whether or not the team involved actually has access to other potential possibilities. So if you weren't using ultrasound-guided peripherals or midlines, how could you say that the PICC was inappropriate when that was all you had in your toolkit? Notice again also here that the tunnel catheter comes up as being a neutral indication when you're thinking about prolonged use of a device. So let me talk to you next about some of the strengths of Magix. First, we had eminent experts from diverse backgrounds, all of whom were focused on vascular access. To my knowledge, this has never happened before in the field, and I can tell you it was time that we did this to actually guide practice. Second, as I hope you've seen, we used a very robust method. This is not only transparent and clear to understand when you look at the methodology, but is also well accepted by policymakers. And as we move to value-based purchasing, I think this is the type of decision-making that will help ensure that appropriateness is weighed into decisions for payment. Third, as I mentioned at the outset, I think Magix is a key step towards measuring, evaluating practice. We now have a way to benchmark hospitals, to look at teams, to look at performance, such that we can weigh the appropriateness of practice from one team or one hospital compared to the other. And finally, we did focus on controversial areas, and so I think we advanced science. For instance, we have a recommendation on tip position in the right atrium. The panelists felt almost unanimously this was not an inappropriate position for the PICC tip, that the PICC tip should remain there and not be adjusted if it's in the right atrium position. There's emphasis on lumens, on gauge. There's also emphasis on the role of consultants. And we focused on important populations that I think have really not been focused on as well when it comes to PICC use. For example, the patients with chronic kidney disease and the patients in the nursing home. Another strength of Magix is this, that there are simple tables of best practice. So here's an example of a table. Notice we have appropriate PICC practices and inappropriate PICC practices. Just an example for an appropriate PICC practice is following non-EKG or non-fluoroscopic guided PICC placement. Verify the tip position via chest x-ray. Similarly, prior to ordering a PICC, and this goes for all physicians on the call, think about consulting relevant specialties, infectious disease oncologists, as well as the operators, vascular access professionals, to determine whether or not this is the right choice and the characteristics of that choice. Note also that we have inappropriate PICC practices. An urgent request for a PICC placement in an unstable patient in the wards or ICU is not appropriate. It takes time to put these devices in, often less time than we have. Notice also that we have recommendations about placing a PICC on arm dominance. This is not an appropriate practice. And lastly, routinely removing PICCs that are clinically necessary without objective evidence of bloodstream infections. I think Magix also has a key strength of that it can change practice. Let me share with you data from a hospital in Michigan that actually tried to do this. So this is data from a local hospital in the state of Michigan, which belongs to one of 51 hospitals funded by the Blue Cross Blue Shield of Michigan. This is my clinical laboratory. At each of these hospitals, we have nurse abstractors that collect all of the data. They focus on PICC use, including patterns of use, appropriateness of use, and complications. And they get data directly from the electronic medical record. So we get very granular data of PICC use. One hospital decided that they would use Magix to improve the appropriateness of PICC placement. Here's the data from this hospital. Let me walk you through the slide. So this hospital placed approximately 100 to 120 PICCs per month. Notice the colors of the bar. The green is single lumen, the purple is double lumen, and the teal here is triple lumen. And you can see the hospital placed very few single lumen PICCs relative to the multi-lumen devices. Also note that there was some moderation of consults and placement happening in the hospital. The vascular access team was very proactive. They did not give a PICC to every single order. They were trying to moderate which PICC should go in and when, and decided that they would use Magix to do this. What happened when they implemented in August? Here's what this looks like. Not only did their PICC use drop, it dropped by almost 20%. And when you look at their overall PICC use, that remained fairly sustainable and steady over the course of time. Similarly, the use of single lumen devices increased dramatically. Notice here it's about 50% of overall PICC use, compared to here where it was less than 10% of devices. And a strange thing happened with the consults. Physicians stopped requesting PICCs because they began to realize that they're not going to get this device like they used to anymore, that there is now a criteria or a standard by which the appropriateness of a PICC will be evaluated. Now, this hospital is outstanding in many ways because they actually not only decreased inappropriate PICC use but saved money. They decreased occlusion events by approximately 48%. They dropped their VTE and CLABSI by almost a third. And look at that drop in PICC less than 5 days, by 60%. We did some behind-the-scene calculations, and we estimate this hospital saved $610,000 in costs just by this one intervention alone using MAGIC. It's not just about those specific interventions. Let me show you data now going into 2016. This is the proportion of PICCs placed for less than 5 days. And as you recall, that dropped substantially. But look at this data from more recent times. It has continued to drop after the intervention has gone into place. Here's similar data. This is looking at the percent of single lumen PICCs again in this hospital. Notice how after the intervention that has just continued to increase because physicians have begun to realize that they can get what they need with this use of this tool and with the use of MAGIC. Here's PICC placement in GFR less than 45. And you can see again, there's been a downward trend in placing PICCs in these types of patients. And finally, here's ICU PICC placement for less than 14 days. Notice how much this has decreased substantially since placing MAGIC in the record system. I also want to point out these two bumps here in the line curve. Why do you think these happened? Well, I can tell you why. The vascular access team decided to implement this without bringing the ICU physicians on board initially, and they weren't having any of it. Only after they met with the ICU team and discussed what they were trying to do and why they were trying to do it did they have buy-in. And look at the great drop in overall PICC use. It's been an incredible success after they got stakeholder agreement on the actual mission of the proposal. But it's not just these hospitals. This is data now from almost 20,000 patients across 51 hospitals. We've been hard at work, and we're showing you data now that suggests that we've been able to increase the rate of single lumen PICC use across all of our sites in a very significant way. At the same time, we've been able to decrease the rate of triple lumen PICC use, almost by 3% or 1/3. Again, this is statistically significant across all of our hospitals. And finally, our rate of PICC dwell less than 5 days, that short-term PICC for peripherally compatible therapies, we've also been able to make a substantial decrease from 24% at baseline down to 19%. Now, I know many of you are thinking, this is great, but how are these changes happening? How are hospitals able to take MAGIC and actually make them change practice? Well, it's not a secret. The secret is vascular access teams. Across all of our hospitals, the vascular access specialists are driving change. Most of the MAGIC interventions that are being put into place here are being led by these nurses with or without IR or surgery support. At hospitals that don't have vascular access teams, it's the IR physicians who are actually leading the charge. One key thing that I would recommend that we've learned along the way is the importance of having a vascular access committee. This includes a physician and a nursing champion, and they both agree to support one another and find solutions. Hospitals that have been able to implement MAGIC and improve their overall appropriateness of PICC use have almost universally developed a committee of this sorts. And finally, I say this from personal experience, it's really important that you measure what you're doing, because showing reduction of complications and cost and return on investment to leadership is the most important thing. It really will help you get buy-in for continued progress with MAGIC. So let me end with some conclusions. First of all, I think MAGIC is an evidence-based document that provides guidance on which vascular access device is most appropriate. Hopefully you've all seen that. I think MAGIC's unique strength is that it bridges the evidence with expert opinion using a well-defined and transparent and rigorous process. I've shown you data that suggests that MAGIC can improve outcomes and reduce cost, but I think it's early for us to start thinking this is the solution to all of our problems. We need further validation studies that not only examine the benefits of MAGIC, but also the downsides of using this tool when it comes to actual clinical practice. I hope you've enjoyed this conversation. If you'd like to know more about MAGIC, I invite you to visit our website, improvepic.com. Click up here on the MAGIC tab. You'll be able to access the document as well as resources regarding MAGIC and how it's being used in various hospitals. Over to you, Nancy.
Thank you, Dr. Chopra, so much for your excellent presentation. As a reminder, I wanted to let you all note that this webinar is accredited for continuing education, both for nursing and for physicians. The on-demand version will also be accredited for both CME and CNE, and you can also direct others to watch this program and they can then get the continuing education as well. You can see here this link, www.saxtesting.com/SA/ that you can log into the on-demand version, complete an evaluation and the post-test. Upon successful completion, you can then print your certificate, which proves that you have continuing education for this webinar. So at this point in time, we can now accept questions from the audience. Dr. Chopra, we have about 15 or more questions that have already been submitted, and so I'd like to start with a few of these. One of the ones that I think is most pertinent was given to us from, I'm checking the name, Kristen, it looks like. Where can she access the MAGIC guidelines?
That's an easy question to answer, Kristen. Thank you for asking. So we've created a website, improvepic.com, as I showed you. There's a tab in the upper right corner called MAGIC, and when you look at that screen, you'll see pictures of the actual meeting. There are a number of buttons at the bottom that include more about the press and media coverage, some of the work that we're doing across Michigan, and there's a button there that has a download your copy. And if you click on that button, you'll get the entire PDF of MAGIC. I will also add that there is a contact button on the top right-hand corner of the main menu, and all of those emails come to me and my team here at Michigan. And many of you have multiple questions that come up after you read MAGIC. Some of the common ones include, what do you consider peripherally compatible, given that INS changed their standards and recommendations around the pH and osmolarity requirements? And we're happy to answer those on a case-by-case basis. But I highly recommend you visit the site. I think you'll find what you need there.
Oh, that's super information, Dr. Chopra, and it also provides you with a means to send your questions if we're not able to get to everyone's. The next question that I have is from Jessica. How do you get your physicians to buy into MAGIC? Some physicians think that they should always get exactly what they order and want to argue about the appropriateness.
That's a great question. Thank you for asking, Jessica. Well, I think one of the reasons physicians do this, and this comes from my experience as well, is they don't really know the science. They don't understand that there is actually a rationale behind choosing one device over the other. This is why myself, as a physician, decided to take this on as a project of ours. Now, we published MAGIC in one of the topmost journals in medicine in the world. We had to go through a rigorous review process, and the beauty of it is it's written by a physician for physicians. So whenever you encounter a difficult physician, my advice to you would be to pull out MAGIC and say, well, look, it's right here in one of your top journals written by one of your guys. So it's not as if I'm making this up. It's actually what's recommended in the evidence. It continues to surprise me that many people out there come to me and tell me that physicians haven't heard about MAGIC or actually haven't talked about it, in comparison to how many vascular access specialists, such as you, Jessica, and others, actually have read the document. And so I think the beauty of this is that it's a tool that will help you have these conversations. Again, my advice is not to make this about a position or a particular type of practice. It's about the evidence, it's about the document, and presenting them this document to read is the first step to actually getting buy-in. The other thing I will say is, and I mentioned this briefly in our conversations, is it's really important to find a physician champion. I think these are the types of battles that you yourself are not going to be able to win. And having an ICU physician who's respected or a hospitalist who's respected actually give you a little bit of leeway to say, I'm willing to hear you out, show me the document, allows for that conversation to take place, because then it becomes much more likely for you to get buy-in with physicians. And last but not least, there's only one of me, but I will say this, I've often received emails from people saying, boy, our physicians are really difficult, can you help us? I am more than happy to send an email to them and have a conversation on your behalf. Again, there's only one of me, but I'm happy to do it.
Well, Dr. Chopra, we have loads of questions for you, and so I'm going to try and jump around and lump some of them together. Anne asks, are there differences in thrombosis between centrally placed PICCs and midlines?
That's a great question, Anne. I think the data on midlines is very difficult to sort of draw conclusions from. A lot of the data comes from the earlier, older midline devices that were placed in 2000 and 2001, had very high rates of phlebitis and extravasation, and unfortunately were no longer favored over the course of time. There were also reports of high rates of thrombosis in the early part of the century. I will tell you that the data on midlines today appears to be quite different, that there are continued concerns about midlines in terms of infiltration and extravasation, but there are a lot more midline devices available than there were 10 or 15 years ago. And there's a lot more expertise now with ultrasound to be able to place them. We are currently doing a large study across our Michigan hospitals to start to collect midline data to understand specifically what is the rate of thrombosis with a midline that is also not just a midline device, but a PICC trip to a midline position versus another type of central catheter, such as a PICC or a central line. These data are coming soon. I can tell you we've collected data now on a few hundred cases already, but there's no good way for me to answer that question yet because the evidence simply isn't there.
So we had some additional questions also on midlines and concerns over midlines that were being used that caused leakage after 2 or 3 days, and then physicians having to order replacement of PICC lines. The question is specifically, do you have some recommendations on how that can be managed?
That's a good question. So I will tell you a tale of 2 hospitals, both of mine, where we are currently working with midlines. At one hospital, the results have been fantastic. The same device we see dwell for 15, 30, even 45 to 60 days, maintain not only flow but also blood return for lab draws. At my other hospital, same device, we don't see those types of results. We see quite the opposite. Midlines occluding, infiltrating, leaking. How could this be? How could the same device have very different results? I think part of the challenge with the midline data is that there is an art and science to placing a midline. It's not like placing a PICC, and I'm slowly learning more and more about this. There are specific geometric considerations with the midline. You have to choose the right size vein. You have to make sure that 50% of the catheter or more is within the actual lumen of the vessel. And you have to watch it very carefully, especially when you're going deep, because extravasation is always possible. I think these types of issues are the ones that specifically need to be studied. There are no good recommendations yet for preventing it, and I can tell you I struggle with both of our hospitals trying to understand what the differences are. But I'm convinced it has to do with the insertion practice, and I'm convinced it has to do with the maintenance and detection. And if it's done right, I think we can see good results. But we will be studying this in both of our hospitals and across our Michigan Hospital Medicine Safety Consortium, so stay tuned for more information.
And thank you, Emily, for that question. Now we had at least half a dozen more questions on midlines that were talking about evidence-based lists of medications that can be used. So I just want to state for everyone that the Journal of Infusion Nursing in this January-February 2017 edition had a specific article with a list of appropriate medications for midlines and PICC lines, or those that should not be infused through peripheral catheters. So I want to refer you to that. Also, there was a question specifically from Mark that talked about, as they begin setting up their vascular access team, they have 2 experienced RNs and they expect this to grow. Can you address some of the pitfalls or suggestions that you might have from them in developing this team?
That's a great question. Let me also add, Nancy, to the INS non-cytotoxic medication list. So this was it's a very useful list. It talks about medications at high risk of extravasation and medications that you may want to consider for a central venous access device. But remember that there's a difference between drug and dose and concentration. If you can dilute vanco enough, you can give it through a peripheral line. In fact, most physicians I know will still give vancomycin empirically for the first 48 hours through a peripheral IV. It's only when you know that you're going to need long-term access where that solution becomes non-tenable. So keeping in mind that static list, never forget to think about your clinical practice, because the clinical practice and the context is most important when it comes to choosing which device is most appropriate. Now, as
Perfect
for the second question,
information.
I'm sorry, Nancy, go ahead.
Thank you. Excellent information. Thank you. Go ahead.
Sure. And as for the second question on how do you build a vascular access team and what pitfalls you should avoid, Mark, this is an important question. You know, and as I tour around Michigan and meet many of our hospitals, I've seen sites where there's 1 or 2 vascular access nurses stretched between 2 or 3 hospitals. And they're often getting calls from the ER, they're getting calls from the floor, and they're running around trying to do the right thing. So a couple of things I want you to keep in mind. Number one, I would like for you to always remember that you should not be a procedure service. And what I mean by that is if you're going to start to be the person that places a device and that's all you do, then that's exactly the type of respect and the kind of jobs you're going to get. Put the device in for me. I view vascular access nurses as having a specialized body of knowledge, a specialized skill set. I view them more like consultants. And I think for you, it's really important to set that tone very early, that you're a team that's here to do what's best for the patient, that you have a special set of skills and expertise, and that you're going to weigh each of the individual recommendations or orders individually to come up with what's best for the patient. My second piece of advice has to do with hiring. I've met a lot of vascular access teams that have struggled because they have hired the wrong people, or they've hired people that haven't stayed around long enough, and turnover is very, very challenging in this field. So I would say hire hard. There's an old saying that I always believe in, and I tell all of my mentees, A's will hire A's while B's will hire C's. And you should focus on hiring A's, because if you get the right people, trust me, you will change the culture of an organization. And last but not least, I mentioned this in Magic, it's important to measure what you're doing and how you're doing it. If you can go to your leadership and say, I use an evidence-based document, here are our insertions, here's what we think is appropriate versus not, then I'm telling you in the value-based purchasing era that we're in today, that will only get you more buy-in to expand your team, get additional technologies, and try other things. So those are the 3 recommendations I have for you when you're starting off young and you're starting off small.
So another question from Christy is about addressing picks that were not appropriate. For patients that didn't receive a pick, what did they get instead?
That's a great question, Christy, and I assume you're referring to the study I showed you that was done at one Michigan hospital. And let me tell you about this study, and let me tell you about our experience at the University of Michigan as well. So at the study that I showed you where the use of PICCs dropped dramatically, almost half of those patients didn't need a central venous access device. A majority of them actually didn't even need a vascular access device. In fact, most of these were difficult venous access patients that needed a blood draw that they were able to get, or a patient that needed an antibiotic dose that could be switched to the oral route. The learning from this story at this one hospital is that this was not just inappropriate PICC use, but it was avoidable PICC use. Now, a number of them actually did get midlines, and this hospital has really developed a very robust midline program such that they now have the ability to place these devices in a lot more predictable fashion with much better outcomes as well. From the University of Michigan side, I can tell you this has been an ongoing challenge for us because we're very big and change is hard to come by. What we have instated specifically for the chronic kidney disease patients is a hard stop. And what that means is if a patient's creatinine at any point in time during their hospital is 2 or more, the vascular access team will refuse or say no to PICC placement without there being approval from a nephrologist. And I will tell you, at my university hospital, I have yet to find a nephrologist who says it's appropriate to put a PICC when your creatinine is 2 or higher. Many of these patients end up actually getting a much thorough look as to what is trying to be infused and why. And if appropriate, they get a device such as a small bore central catheter or a tunnel catheter to avoid the veins of the arm. But in my own limited practice, I can tell you many of these patients actually don't need a vascular access device and can work on orals and or transient devices as and when needed.
That's great information, Dr. Chopra. We also have a question from Marcia on Looking at the advantages of single lumen versus multi-lumen catheters, can you talk a little bit about that?
Sure. So Martha, the recommendation for placing more single lumen devices has to do with complications. There's a lot of data from central venous catheters that suggests the more the lumens you have, the higher the risk of bloodstream infection. We've shown this to be true as well as with PICCs. In fact, because PICCs are most often used in non-ICU settings, often in general medical wards, we found that CLABSI that happens with PICCs often happens after the 7th or 8th day and often has to do not with an asterile or aseptic insertion process being violated, but with the manipulation of the hub and manipulation of the lumens. And the more the lumens you have and the more you manipulate, the more likely you are to see problems with catheter care and maintenance and infection. So that's number one. Number two, the more lumens you have, the more cross-sectional diameter you need for that catheter. And Scott Evans and others at Intermountain and our team has also shown that as your PICC gauge goes up, which often happens with lumens as they're increasing, you end up with a higher rate of thrombosis. There's a team in Canada, McGill University, that went to a single lumen PICC policy. And what they basically said was everyone gets a single lumen PICC unless or until there is a reason for a multi-lumen device. And they created a number of reasons, such as TPN, for instance, or chemotherapy. What this hospital has been able to do is increase their single lumen PICC use up to 65% across their hospital. And as soon as they did that, their rates of CLABSI and DVT dropped dramatically. Just like the hospital I showed you in Michigan that did exactly the same thing with increasing their single lumen PICC use. We've done the same thing at the University of Michigan. We have a project ongoing right now that's entitled Less Lumens, Less Risk, where we have an evidence-based recommendation for what type of devices should be multi-lumen and which you should insert. If you go to the Improved PICC website and click on Resources, you'll see what these recommendations are. We've been doing this now on 2 services, and I'm happy to tell you we've actually achieved 85% single lumen PICC use without there being significant downsides to patients with respect to incompatible medications or issues with clinical care. We've also started to see a dramatic reduction in our CLABSI and DVT rates. So stay tuned. That paper will hopefully be written and out soon. But again, Improved PICC on the resources page, you'll find the Less Lumens, Less Risk document.
Excellent. Thank you so much. We had multiple people that chimed in asking specifically about whether Magix would apply to other care settings. From Sandy and Craig, they talked about how Magix is mainly hospital-based. What do you think the crossover might be, Dr. Chopra, into other care settings?
That's a great question, Sandy. I think it's difficult. You know, it was hard to do this for the hospital alone, let alone including other sites. But there's a number of things there that I think we've been able to do with Magix that potentially are relevant. So one big challenge for us has been our nursing homes. A lot of our skilled nursing facilities did not accept patients with midlines. They were worried about premature failure, extravasation, etc. We set up a pilot program with one of our local community facilities to try this. Again, using Magix as the tool to be able to say if a patient is going to a nursing facility, there's no reason that automatically qualifies them for a PICC. There are other devices that may be more appropriate and safer given the resources available at the nursing home in mind. We've done this at 2 facilities now. We've been able to use midlines with actually relatively good outcomes. We'll be publishing this data soon. I think that's an example of how Magix can be used. The other aspect I think is relevant here is the fact that Magix is a series of recommendations. And those recommendations are true regardless of site. So for instance, when you place a PICC in a nursing facility or in an LTAC, I still think you should be thinking about tip position. You should be thinking about lumens and gauge. You should be thinking about, is another device appropriate, and or does this patient really need a central venous access device? I think Magix can help inform those decisions, perhaps not as directly as the hospital, but in a way can help you make a good sound judgment as to whether or not you think you're doing the right thing. Again, if there's adaptations of Magix or if there's things you think you are relevant, I've heard from many people who've taken some of the recommendations, even the square algorithms, and put in different time frames because that works best for them. I don't think that's unreasonable. I'd love to hear about it, so please email us again on the Improved PIC website. We'll definitely take that into consideration when we think about actually publishing more data on MAGIC and its use in non-hospital sites.
Wonderful. In an effort to try and combine multiple questions, there were quite a few comments on terminal tip placement for midlines, the use of ECG for PIC lines, RA placement, and what's most appropriate. Do you think you can quickly address some of those issues, Dr. Chopra?
I'll do my best. We have a couple of minutes. So first, I think the position of the catheter tip, as most of you know, is really important. It has to do with blood flow at the cavo-atrial junction, hemodilution, and prevention of thrombosis. There's numbers of studies out there that show any PIC tip that doesn't reside at the cavo-atrial junction is actually associated with a higher rate of thrombosis. The controversy is the right atrium. And the right atrium position has always been one of those things that has resulted in a PIC being adjusted. Sometimes, so much so that when you look at phases of respiration, you can see the PIC moving up and down, and you're catching an X-ray at one point in time and adjusting away without there being a clear understanding of this being the appropriate spot. The data for right atrial tip positioning and the fear about it comes from very old studies. Mauro Piderudi, who many of you will recognize, has published a great paper about this where he reviewed all of the evidence about tip positioning and found that there really is no good evidence to suggest that the right atrium is an inappropriate position for the PIC tip. In fact, when you think of dialysis catheters, that's exactly where we put them, in the right atrium, because we want to avoid dislodgement, we want to avoid tip malpositioning or migration. So I think that cavo-atrial junction or right atrium are perfectly appropriate positions. We do this at the University of Michigan and at our VA center here in Ann Arbor. We have not seen an increased risk of adverse events. I know many other sites are doing it as well, and we think this is the appropriate spot for a PIC tip.
So in order to address some of the issues that are have come in question-wise on midlines, Dr. Chopra, do you feel like that you could provide future webinars or presentations on issues of midlines, and also any interest in leading a mini MAGIC educational program specific to the pediatric patient population? Thank you to Stephanie and Elizabeth for those.
Those are great questions. So I've received a number of comments about midlines. We are going to start looking at this in Michigan. I think we need more information. I also think we have to understand when we say midline, we're referring to a host of different devices and a number of devices that are simply trimmed PICs. And there are differences there with outcomes and things that we should be actually thinking about. So the one size does not fit all, and we need more evidence there. I'm happy to sort of share data as we start to collect it at Michigan hospitals to show you outcomes of midline use. And with respect to the mini PIC, Amanda Ullman and Tricia Clyden, who are in Australia, have asked me this for about a year. I will tell you my enthusiasm to create a mini MAGIC is limited only by the effort that's required. It's not an easy process, especially when the evidence for pediatrics is more limited than it is for adults. But I do think we need a separate document to help with guidance for pediatrics. They're not little adults. There are unique issues, not the least of which is securement, and happy to partner with them to create that document.
Excellent. Well, thank you so much, Dr. Chopra. We appreciate your presentation, and we have come to the end of the hour. Thank you to everyone for all of the excellent questions. Apologies for not being able to get to everyone's, but Dr. Chopra, you were able to provide them with that improved PIC access for the emails. And thank you all for your attention, and thank you, Dr. Chopra, for your time.
That's right, Nancy and Doctor, thank you so very much, and I want to thank you for both of you giving such a wonderful and exciting presentation. We had so many questions, and you did a great job getting as many of them answered as possible. Finally, last but definitely not least, I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time. Dr. Nancy, thanks again.